Hey y'all, and welcome back to the latest episode of Code Brew. This is Joe King, and I'm here with my co-host, as always,
Lukewarm. Hey, it's Luke.
It's Luke. So, we're really excited. We're always excited to be here, aren't we? I mean, we say that every time, right? But we have been playing this for a while because our very dear friend.
I mean, I'm really excited to have this one.
Yeah, to talk about. I mean, we were excited just for our friend Norma to be on too, but yeah, I mean, when we have a guest, I think that now that we've started having guests, like we're glad. I'm just glad I don't have to always look at Luke all the time. I have somebody else. I have a different friend to talk to.
So much
here. So we are diving into the fast-paced world of the CVIC today, and we have Lora Zappem.
Zappem.
Oh, that is a mispronunciation. Zappem. Her name is Lora Zappem, for God's sake.
She's very clear about it. It's not Lora Zappem.
It's not Lora Zappem. It's Lora Zappem.
I zapped them. That's how I
zapped them. No. Yeah, so this is super fun. So she's a CVIC nurse, and she can introduce herself. Go ahead.
Well, hello. As Joe said, my name is Lora Zappem. I am a CVICU nurse. I have been a nurse for 8 going on 9 years now, and most of that time I have been a CVICU nurse, but I've dabbled in a variety of other types of nursing. I started off as a brand new nurse in the med-surg world, specifically orthopedics.
Oh.
Yeah. I started to like it for a little while, and then I just got kind of felt like a drug dealer.
Not starting out on mixed acuity or med surg or whatever, because I'm a big fan of that, but it's a very big floor.
For my experience,
a lot of this
really stable.
Yeah,
I didn't have any I shouldn't say truly sick, because almost every patient you encounter has some sort of comorbidity. Mm-hmm. But for the most part, my patients were really stable. Granted, working in the med-surg world, I had never even experienced a code. I'd rarely had to do a rapid response on my patients.
Right.
If I did, it was usually just because they got over-sedated and they needed some Narcan. And really, that's not to say it's not a reason for rapid response, but I could have done that on my own as a bedside nurse.
Right.
Maybe didn't have the confidence to do it, or the know-withal to do it.
But how fast can you admit a patient?
Oh, so quick.
How fast can you discharge a patient?
Yeah. So,
whereas I'm struggling, I'm oh my gosh, a discharge, ICU at night, whatever. I'm how do you do this?
Yeah.
So a bed in 30 seconds.
So I did that for 2 years. While I was there, I also started a journey of education of new nurses.
Educate.
Yeah. So I started precepting while I was on that unit. I actually discovered I really, really enjoyed it. I like kind of watching those light bulbs go off in the nursing students.
Don't we all?
Yeah.
All of them.
I kind of think, did you ever play the Sims game as a child, and they had that little diamond figure over there?
The Sims game as an adult.
Oh, my husband just posted today. Literally today. I've been playing this game for 25 years. And I was oh my gosh.
That little figure over their head, but for nursing students, it's literally a light bulb. And all of a sudden, one day you just see it and I'm there?
Yeah.
So anyway, I really enjoyed that.
Yeah, I've grown up nurses.
Yeah. Eventually, I decided to go back to school. And after I finished my bachelor's, I went back and then I did my master's. So I ultimately have a master's in nursing education.
Mm-hmm.
So I've...
This is fun. Yeah, is it a doctorate now?
Doing a doctorate.
My gosh.
Going back again. I'm an addict for learning.
Or she's got some crazy casino debt that she's trying to avoid repaying her student loans.
Yeah, but so after
school forever, you never have to pay your student loans back.
Well, what will you do after this?
Well, what do you mean after this?
Your doctorate, a second doctorate?
No.
You're good.
I think I'm done.
You're going to work.
And to work.
Okay. Yeah. You are going to work. You are going to work.
Sleep and work.
Okay, nice.
Yeah. But anyway, so aside from my obvious CVICU education that we're going to talk about today, or experience, and then I've got med-surg experience. I have done
Response like us, yeah.
yeah, and then also house manager and
Ew.
yes, me, I know.
I'm that.
And then current now I'm a travel nurse even, so I've kind of dipped and dabbled into a little bit of everything.
Yeah, that is awesome.
Kind of everywhere, anywhere a nurse can be. I'm probably been there or gonna get there one day.
So, okay, so awesome. You are very uniquely qualified for what we want to talk about today.
Thank you.
What? So yeah, we are excited to have you as our second victim. Guest. And one bit of housekeeping before we get started. So the views and opinions expressed on Code Brew are solely our own and do not represent the views of our employers, professional organizations, or personal or professional affiliates. This podcast is for educational and entertainment purposes only and should not be considered medical advice.
Yeah.
So, okay, so the first question I have for you is a fun one. So if you can describe CVIC in 3 words, what would they be?
It's kind of a tough one.
I do.
I would say hard.
Yeah.
It looks hard to me.
Well, I thought I was describing it.
Oh, sorry, my bad.
Yeah, I would say that it is organized chaos. So that is 2 of the words. The other third word I would probably throw in there is busy. But then if I could maybe throw in a 4th one, rewarding.
Intimidating. Oh, like,
Yeah.
all the devices.
All of them. All of
The devices, they scare me.
All the devices in the same room, on the same basis.
Everything's
multiple
that we could possibly do for a patient. We've taken over every single body system, and there they are.
Everything is at rest. Yeah. It's kind of weird. I always was like kind of confused as like why they never really called codes and CVIC. I mean, like you just don't hear a lot of them, and when you work over there, it's like
they're all ECMO
because
they don't even need to code them, right?
Everyone is kind of being. So
they say it's because Lora Zappem is there.
Lora Zappem, yes, she's there taking care. Everybody's body is on complete rest.
Yeah,
like there's no work being done for me.
The work's being done.
Patients are relaxing.
Yeah. Which brings me to my next point. A lot of people think that ICU nursing is kind of like, well, you only have 1 patient, or maybe you only have 2 patients. Like, what are you doing with all your free time? And
yeah, I used to say that in the ED. As ICU nurses were like, they never do anything. They're watching.
I mean, sometimes it can't. Sometimes you can have a really good 2-patient assignment, or whatever, like a 1-patient assignment.
Must be nice to only have 2 patients.
Sometimes
nurses have never had an insulin drip and all the other crap we have to do too.
Well, titrating like so many different.
Yes, 100% true. I take care of specific patients in the ED for sure. No, I do understand. I'm titrating.
But when you're running
15 minutes,
when you're literally like titrating like 10 things and have like continuous electrolytes going, and you're drawing labs multiple times a shift. Like a lot of, kind of like the standard of care in other areas is maybe like labs every day or labs every other day. And it's like, oh, we're going to do this every 6 hours.
Yeah.
We're going to like keep replacing. And you know what? We only believe in IV replenishment, so like, you could just constantly on a K run, you're constantly getting magnesium.
I have to say, like, me, like, I don't intimidate easily, just in general, but like, I get very intimidated in CVIC by all the devices. Like, it seems really scary to me. Like, I'm like, I don't think I could do this, but I mean, I probably could if that's what I was very interested in. I'm very proud of what we do in our hospital for these patients, because the technology is unreal. Like the things we can do for a patient. I started in healthcare like 15 years ago now, and I mean I guess there was ECMO. Hey, not that old. No, it's starting to feel like that. But no, I mean like I feel like some of this technology really wasn't there or wasn't developed to the point it is now. I mean we had ECMO.
Seeing it so much.
Yeah. Yeah, I mean, we had ECMO, but it was basically like just a bridge to transplant, and it was really infrequent and
really not great success rates.
I mean, maybe, like they had to be, extra. I mean, not that they don't have to be profoundly ill, but they were basically knocking on death's door before we even considered it.
Yeah.
Versus, I mean, like, and things like VADs. I mean, like, I remember when we got trained on VADs for the first time. And I was like, what is this? Of course, we all heard about it on Grey's Anatomy. And I was like, oh, okay, well, that's what this is.
And I was like, all of our patients can be as sweet as Denny Duquette.
His lesson, he's on the slide for cardiac assist devices for like undergrad.
Yeah.
Like when they teach about like cardiac assist device and they teach about LVAD, it shows a picture of the Danny guy.
Oh.
Which I was wondering, I was like, is that still relatable to like 20-year-olds? But they all know who he is.
20-year-old nurses or 20-year-old healthcare, not specifically nurses, but healthcare providers.
Yeah, and people. I mean, it's still.
I mean, I'll tell you I was a nurse for.
Sorry, I spilled the beans.
Maybe like 4 years before I went to CVIC, and I remember like the day before I went, it was like Sunday night. I'm trying to go to sleep, and I'm like, should I go on Sunday?
You know what's funny? When I had applied, I actually applied to go to MICU. Because it's kind of all I really knew about. I think I'd maybe like had a friend or two in MICU, which is medical ICU. So it's kind of just like a generalized ICU. And somehow, some way, my application got forwarded to CVI. I guess they were short nurses. Hi. They were short nurses, and so that's where I landed. But when
they needed ortho nurses.
They're specifically for nurses who knew nothing about the heart. I were like, please train you.
Is their leg broke?
Yeah, but so I ended up. I mean, I got shifted over to CVI, and I knew nothing.
Mine was a weekend position. Like, and I remember talking to the towers manager later, and she was like, "We could create weekend position. We can create." I was like, "Oh, okay, fair."
Yeah, I feel like I knew nothing about what happened in the CVI before I got there. So I think some people, like, when they're in nursing school, they know, like, I want to be specifically in ICU, and like I want to be specifically this kind of ICU nurse.
I want to be the baddest of the bad.
No, keep me away from that. I just want like someone who's kind of sick. Like, give me something.
Well, yeah. I mean, you gotta, yeah.
And then you got,
and somehow I went the far end of that.
Yeah. You just go from one extreme
to
the other. I guess I never really thought of it. You went from outpatient same day surgery, basically. Sometimes they stay the night. To we live here.
Like they stay there for months. Right? I have to say respect. Like I mean, obviously ED nurses are the absolute baddest of the badasses, but you CVIC nurses are like a close, well, not that close, but kind of a close second.
She's not biased.
No, I know. I mean, it is. It's like they do some amazing things. So it's pretty awesome, I have to say. But let's look at the patient population. So you're what are you seeing mostly in these patients? I mean, I know we're going to talk about the different devices. We're going to talk about the surgeries and stuff. But what makes CVICU or CVIC, what makes it different from other ICUs, and what's your typical patient population?
Let's see. So I would say that when I think about specifically, like if I'm going to get a patient directly from the OR, most likely they're going to have had a CABG procedure, which is a coronary artery bypass graft. Most likely they're going to have a CABG procedure. Right behind that, they're going to have valvular work, whether it be a replacement or repair. Sometimes you're going to get patients who've had a little bit of both of that. I'd say that's probably the most like standard type of patient. I'd say that on average, at least the CVI that I most recently worked in, they would do anywhere from like 3 to 5 or maybe even 6 surgeries a day. And that very possibly could have been all of those surgeries that day. But aside from that most common procedure, and not every CVI will do this, but we also, CVI can expect to get transplants. So specifically heart transplants. And then depending on the unit, they might also take lung transplants. But I've heard some facilities are starting to send their lung transplants more to medical because that's where the pulmonary doctors are. So like your pulmonologist, obviously.
Right. Oh, yeah.
But I think that's kind of facility specific.
Right.
But
physician specific.
Yeah, maybe even physician specific. In my experience, I've also taken care of the lung transplants. But
yeah, no, I mean, so CT surgery, don't they do both? Don't they do both the heart and the lungs?
Cardiothoracic.
Yeah, so I was thinking. So.
They do. At the facility that I'm at now, that's kind of a topic and up for discussion kind of thing, because they specifically want the pulmonologist monitoring those lungs. So I'm curious to see if that follows through, if that happens. And I'm also curious to see if other facilities do that. The facility I was at most recently didn't do lung transplants, so I can't speak to that one.
Right. So, I mean, but the lungs, they come out on ECMO devices and stuff. I've never seen ECMO outside of a CVIC. So.
Yeah, I'd say ECMO is pretty exclusive to CVI. I think that's probably our most typical, like, surgical patient. But then aside from that, too, a lot of times we'll get patients who are in heart failure, who are in need of assistive devices to support their heart. Sometimes those devices are temporary. That's kind of always the goal. We always hope that they're just temporary. But sometimes they do need to be permanent, which would still make them a CVI patient.
So for like the temporary, you're talking about like balloon pump,
yes,
the impella,
later, but specifically impellas and balloon pumps.
Yeah.
Impellas, I feel like, are kind of the more hot on the market thing, but balloon pumps are definitely.
My gosh,
they're
impellas are everywhere now.
Impellas are everywhere.
They are both real fancy looking. And then your VADs, obviously we do the VADs, and yeah.
The interesting thing with the LVAD, like this always kind of confused me how they would call them like bridge to transplant. So like, okay, we're gonna put this LVAD in you, and it's going to help your cardiac output, and it's going to be a bridge to transplant. So the goal for you is like, you qualify for a transplant, we just don't have it available for you right now. And then like the destination therapy, like when they say that, and it's like, oh, like this is all you're getting, like kind of like final destination.
Yeah.
But then the destination people could actually like start feeling better and maybe like exercise more and maybe like meet some of the criteria that they weren't meeting before, that was putting them on like the exclusion list. So I kind of always thought that was interesting, because I saw some destination therapies that actually, like got better because they felt so much better with the VAD. They reacted so well.
This kind of technology really blows my mind. But sometimes I'll take, some of our nursing students that are with me, sometimes down there, because they otherwise don't get to see this kind of stuff. Like,
don't know it exists.
Right. I mean, they don't. I mean, so, and they may cover it in a book, but they never actually seen it. They never actually seen it.
It's like briefed over in score now. It's like it's. I think we used to talk about it, but it's like a slide now. Like it's like balloon pump. Okay, this balloon like inflates and helps augment. I think that's it.
I love to see, so when we take our students down there and we talk to them about these things, and, some of our friends, I'll have them just explain it, break it down for these students. And they, whenever they realize, like, just the stuff that we can do for a patient, what we really can do with what the different body systems we can take over, and the technology that's been needed to do that. I mean, you think like, I was listening to a podcast recently that talked about medicine, and I actually posted it on our socials. We were talking about From History That Doesn't Suck. He did an episode about medicine in the Civil War, and like, I don't know, it just kind of struck for me. I had this moment how far we've come since the Civil War, and because that was like the advent of nursing and everything, and how far we've come to this point where we're able to, like, we breathe for people. We take over the kidneys, we take over the heart, the lungs, we do it. Well, we don't really take over for the liver. That one's pretty hard. Yeah, we haven't figured that out yet. But I mean, the things we can do technology-wise, it really like blows me away. I mean, versus like back then,
I don't know. We might take over for the liver with that lactulose.
I know. I'm like, hold on. Like, we're getting rid of the ammonia. Like, we're.
I think you talked about that on an episode.
Yeah.
Yeah.
I mean, I don't know. I just feel like we can do so much for people now. People are living through things that are astounding. And a lot of those devices come in for CVIC. That's why one of the reasons I thought this was really, I was really excited to do this episode. Is like make sure people know, like, we can do some cool stuff as nurses and the things you can provide your patient. And I think it's important for students to know that you can really be a part of saving people's lives on a different level in the CVICs. So the difference between CVIC and other ICUs, like, what do you feel like is like the primary? I mean, the devices, of course, but what else do you feel like makes it really unique?
Well, I can't. Let's see. I've never officially worked in other ICUs. I've been pulled to other ICUs, meaning like worked there for the day kind of a thing. Mm-hmm. So I don't feel like I could truly speak to this deeply, but I would say that just my surface level observation is that with CVICU nurses, we are very driven by numbers. Very, very driven by numbers. And we will constantly be monitoring those numbers. So we may be doing full hemodynamic numbers, which is SWAN numbers, CVPs, obviously blood pressure, a variety of different numbers. And then really digging deep into those numbers. We might do those every 4 hours. We're assessing those changes that are made every 4 hours. And then sometimes if I'm adding a certain medication on, like an inotrope that helps the heart squeeze, I'm going to rerun those numbers again sooner than that every 4 hours.
Or a second inotrope, or a third inotrope. Yeah.
Fifth inotrope.
Yeah. You found another one. Yeah.
But then, I mean, aside from, again, numbers, but like we are extremely...
Feels kind of like a OR. Like, I feel like I'm more so than the other ICUs. Well, whereas, I feel like it's like a PACU. I mean, I don't know. Like, you're still, like, you're functioning still with the surgeon, and anesthesia is running at kind of like it's just a 24-hour-a-day process of nothing is gonna wait until tomorrow.
No.
Like, everything can be addressed immediately in real time, and I think that's
one. There's most likely, I would say, maybe not all, 90% of the time, there's already someone within feet from your door.
I mean, it was...
Something happened.
Well, you got
provider right there.
Perfusionist always there. You've got a provider. You've got an intensivist. You've got the surgeons ready.
Yeah.
There's so many people.
Sometimes we push the surgeons away, but...
It was hard to float after leaving CVIC. Because I'm like, well, where's my glucometer? Where's my, you have so much supplies in your room, and you're not used to, like, if I need a central line, it's happening literally in 1 minute. If I need an A line, it's happening right the second.
Yeah. That shows up before you even have a chance to, like, call family and get consent.
Yeah, they're there.
Well, hang on. Yeah. Like, I not only do have to set up, I have to also call family.
So,
do XYZ things for...
Well, and then, like, the standard of care in CVIC is like everybody has an arterial line.
Yeah.
And then you go to like other SUs and it's not.
Yes.
I mean, like, I've been at some facilities and like it's like they don't exist.
Was I think what shocked me when I went to...
I'm like, they're on pressors. What do you mean? Like,
I mean, I'm taking their blood pressure through a cuff every single hour. I could not imagine being a patient in that bed and that blood pressure cuff blowing up every single hour or every 10, 15, 20, 30 minutes. Literally for 24 hours.
Well, but we also have a pressor need. So it's in my mind, it just takes me back to like an arterial line with a constant pressure allows for me to intervene as fast as possible. So 30 minutes. Well, and then in 30 minutes, like if it tells me 120 over 80, and then 30 minutes later it tells me
60 over 30.
It's 60 over 30, right? I guess since we talked about this in like the previous episode. But yeah, 50 over 20, 60 over 30, whatever. How long has it been that? I mean, like that's 30 minutes of hypoperfusion. It's crazy. So like in my head, I can't imagine that. And I've even heard of ICUs that do labs like every other day. it's just it's hard to understand. It's hard to understand like that thought.
I mean, so like, I've worked in ERs that are like high level, like the sickest patients, the tertiary care center, or what I like to call the bottom of the funnel as far as the healthcare system, where all the patients kind of come in and get the highest level of care. And whenever you're working in a place that's providing that highest level of care, it's hard to go somewhere that's not like, even if it's really not necessary because their patients aren't sick, like you've gotten used to having all these resources right here in front of you at your fingertips, and you're like, I don't know what to do with my hand.
Well, and a different level of assessment. I mean, this is the same reason, like when any ICU nurse is pulled to the floor, right, they're given a lower patient ratio assignment, just because they are used to being so hands-on, right?
But you do have, CVIC, you have every resource. I mean, it's whatever you need.
That's my one thing. I'm like, if we could just have a neurologist here all the time, that'd be great.
You don't need a neurologist.
I'm not a fan.
Yes, it involves things.
Oh yeah,
bring a specialist.
Well, we have specialists for that. But they're available.
They're just not there.
No. Yeah. Well, geez, you have a cardiologist, an intensivist, you've got a CT surgeon within a few steps. What more could you have a perfusionist? Come on.
Our respiratory therapist.
Oh, yeah.
Oh, gosh, yes, I love her.
You have 2 RTs, seriously? You have more than everybody else?
The unit I'm on now, they have a plethora of RTs, and it's really a beautiful thing.
They do it all. Yeah. And the RTs, like, especially in CVIC, man, they have a lot of work on them. They're nice dudes. Okay, so the devices. This is what I'm most excited about because I want to learn about these devices. So,
check me to teach you.
Yeah, right now. Let's do it.
Well, what about like hemodynamic monitoring? I think really that's where the hemodynamic monitoring is what's going to lead to the devices.
I'd say my favorite, and this might be probably a biased opinion because I think that what I was going to say is a Swan or a PA catheter, Swan Ganz catheter. I personally really like them just because I feel like it tells me so much information about the heart and how the heart is operating, and whether the left side or the right side is being defective or if my patient's fluid overloaded or not. I personally really love a Swan, but I also think too that the first CVI that I worked in, they were very reliant on Swans. But I also know that there are other CVIs out there who they don't use Swans at all.
Yeah.
So that might just be my personal preference. I really like a Swan, but
I'm a fan also. But yeah,
I really like them. But I feel like if you,
as long as it's not tangled up in all of my lines, but I'm a fan. I like the data.
Yeah, you could ask a different CVI, somebody who works in a different unit who's not familiar with them, and they could be like, no, it's not. They're not accurate, or. I think that it might be just a biased opinion, but I personally love a Swan. I love A-Line.
I
love it.
I want my CVP. I want my PA pressures.
No CVP.
I want my, oh gosh, it's so weird. My cardiac output, my cardiac index. I need all of those numbers. The SVR, yeah.
Yeah, I want it all.
I'm
greedy.
Gosh, I remember the first time, just kind of talking about that critical thinking. I remember the first time that I got, but it's supposed to be 4 to 8. So just if you're looking at stuff independent of maybe critical thought, this is a normal value. So cardiac output's supposed to be 4 to 8. So I went to one of the CVI intensivists, and it was my cardiac output's 3.64, and I'm like, oh my gosh. And they're like, okay, what's their index? And I'm like, it's 2.6, and they're like, so they're doing great, but
hopefully they're
understanding. Oh, okay, it's going to be more patient specific once we add the body surface area. So not just learning the numbers and what's right, but taking it a step further of cardiac output. Well, really, it's going to be much more patient specific when I body surface area.
Everything we look at should be patient specific. You make a good point. This, we learn these
norms,
these norms, these guidelines, but they're not hard guidelines.
Yes.
In that whenever you're a patient, you have patients who hang out. Their blood pressure hangs out low. That's just their natural state, and they hang out at 90/50. Their MAP stays about 70, and they're good. But yeah,
you tell me a MAP's more than 65, but I'm not concerned.
Another good analogy of that is when I would teach my undergrads, and I would say okay, well, what's a normal heart rate? Okay, well, 60 to 100. Okay, great. I'm glad that you know that. Well, what happens if a patient comes in and their heart rate is 50? Then what?
No, 50, literally 59. They'll go. I
want to give atropine. I'm like,
no, I mean, but 59. So they don't understand the differences. They're like, that's bradycardic. I'm like, no, I mean, they're cool.
Yeah.
But the same thing as we're taught that a normal potassium is 3.5 to 5, and if I see a potassium less than 4. I'm like, oh my gosh, what's going on? We got to get it up. They're going to go into an arrhythmia. Whereas, a student, 3.5, they could be on Lasix, diuryl. They could be on 5 potassium wasting things, and they're like, nope, it's good within normal limits. So you got to think through those processes.
For sure. Well, I mean, your patients are just everybody's so different. We have these, they're just averages. They're just averages, a cross-section of the public, of all the humans. And you can't, I mean, it's like the BMI, we can't really sit for
Yeah, so my BMI is okay.
No, it's not.
Am I heart rate of 140?
We're not going to get into that really in detail, but your BMI is not fun. Oh,
boo.
Boo. None of us are.
We're getting shaved. No, yeah. Mine says I'm overweight, and I always feel super offended by that because, I mean, 100 pounds ago, what was I?
Oh my gosh. Yeah, fair.
So, okay. I'm excited. I want to talk about these devices. So let's just go over, a few things. If you were going to explain it to a student, let's talk about these devices.
I like to explain ECMO to my husband. It's fun sometimes because he's not medical.
Oh, so how do you explain it to him, poor guy? He's a firefighter. He's the best too. He's very patient with all of us, our friends.
He was he's not a firefighter yet officially. Well, he's in training, yeah. But he's just started a T course.
A probie.
Yeah. Oh,
he literally
that's cute.
T course yesterday, and he was reading his book last night while we were sitting on the couch, and he was reading
safety.
Ventricular fibrillation.
Oh, he's writing it out.
No, he was trying to sound it out, and I was like, "Are you saying?"
He's trying to say it. Oh my gosh.
He's not medically inclined at all. So he's probably heard me say VFib before, but I'm sure
not putting it together. Yeah.
Or say ventricular fibrillation. I'm sure he's never heard me say that. So it's interesting to
let's teach him things.
Oh yeah, we got to teach him some stuff. It's fun though. But anyway,
I can listen to the podcast.
Anyway, ECMO. I explain ECMO to my husband, or let's say a new grad or someone who's an undergrad, as support for the heart and or lungs, or I should say the lungs and or heart. So you can have two different types. You can have one that is simply just for the lungs, or you can have one that is for the heart and the lungs. But essentially, it's kind of like a dialysis machine. But specifically for your heart or your lungs. Goodness, this coffee is too much for me. I'm getting overwhelmed.
So
anyway, I like to say, imagine if you had two small water hoses, one in each groin, and one of those water hoses pulls the blood out of your body, and we run it through a machine, and it filters out those toxins, and it adds a little extra oxygen back in, and then through the other water hose, we put it back in. Imagine that, and that's ECMO. That's how it looks like.
Yeah, so for VV kind of. Yeah, so and I always explain sweep. It's I'm sweeping the floor, I'm sweeping off the CO2, I'm sweeping off the CO2 and the bad gas.
Yeah.
And then I'm just gonna really oxygenate it really well, and then I'm gonna put it back in your body. So the goal is lung rest.
Yeah.
So we're letting the lungs rest, or treating hopefully an infection or something that we can make better.
When it comes to usually it's an ARDS situation. Yeah. For COVID, we used ECMO for COVID because essentially that really was
so much.
And then you can use it for I think I've maybe seen an infection purpose, maybe a time or two, but for the most part it's usually for ARDS or someone who's awaiting a transplant. I've had quite a few of those patients as well too. But then, so that's VV is just the lung support. And then VA is the heart and the lung. So essentially we're bypassing both of those. This allows the heart to rest. You're still going to have some blood flow going into the heart and into the lungs.
So the lungs aren't completely turned off. So the lungs are still functioning.
Yeah.
The heart is still functioning. So there's a cardiac out, but it's just maybe a liter per minute.
A burden of fluid off of the heart, which if we're taking it off the heart, then naturally we kind of have to take it off the lungs. If you understand the way that the heart works and how the lungs work interconnectedly, if we're taking it off of the heart, we kind of have to take it off the lungs. So, it is very cool.
So fun fact, at our hospital, the ECMO machines are named after Santa's reindeer.
Oh, did they change it? It used to be the 7 Horse.
Well,
I haven't worked at their hospital in almost a year, but it used to be the 7 Horse.
I recently met Donner and Blitzen. So I'm guessing they changed it to the reindeer. I don't remember those.
I don't know if
it's what's actually really funny about that. My last facility in Cincinnati.
We must have bought another one, so there's 8 reindeer.
Maybe.
Yeah.
My last facility in Cincinnati, they named their CRRT machines off of Grey's Anatomy characters.
Oh,
I had this nurse who came to me, and she was a little on the newer side. She wasn't like a new nurse, but a newer nurse. And she goes, "I don't know why, but for some reason there is not a patient label, but a label maker, like a label maker sticker on the side of my CRRT machine that has what was 007's name in Grey's Anatomy?
Was that Alex?
No. I don't want to. Oh my god!
Yeah, the one that died.
Yeah, that's what I
sad one.
Yeah, I can't think of what his name is.
Oh
now,
my
but
god!
it had his name on the side of it, and I looked at her and I was like, "What?" I was like, oh, all of your CRT machines, that's how they identify which machine it's
Oh, yeah.
Because they have them named the different Grey's Anatomy characters on the side of the CRT machine.
Well, yeah, I'll have to think of this guy's name.
That's going to drop me. George O'Malley.
It's going
to drop me crazy.
Oh, my God.
It had George O'Malley on the side of it, and I was like, oh, my God. That's so fun.
Of course, I love our humor. I love our healthcare humor. Like, we find a way. For the most part, I feel like nurses really try to find a way to have fun at work. I mean, as best we can. And I definitely always try to find a way to have. I love my job, so I do have a good time. But no, so I think that was a really good overview of ECMO. Is there anything you want to add?
I think that when I was trained on it, it was like always be afraid of it. Like I have a healthy fear.
I'm definitely afraid.
Oh gosh, like the advocate, like we're gonna lay the patient flat and like watching the lungs and what the turning looks like.
I'm so afraid that you're not turning your patient because that's all, like equally as important. But at the same time, you should have a healthy fear to know that turning your patient could lead potentially to a disaster. So you just have to take those extra precautions to be extra careful when you're doing anything when it comes to that machine or
changing a dressing, anything.
Someone from the X-ray department coming in with their big machines, like just go in the room with them and just ensure that their machines aren't getting hooked up on your ECMO machine and they're not running and bumping into it.
You really have to use a team. Yeah, really. I mean, yes. There's a really high reliance on the team approach. Whenever you have to do anything, when you have to turn your patient, when you have to give somebody a bath or something. I don't think
You're definitely not doing anything alone.
No.
Yeah.
I don't think I ever see just one person.
Untangling your lines.
Yeah. No. So what about the impellas and the balloon pumps? I mean, we can talk about those together, or we can kind of divide them up however you want to. I mean,
well, I personally really preferred an impella over a balloon pump, but there are definitely certain times when a balloon pump has its play
advantages.
It has.
It's a little bit older technology.
It is. Yeah, it's older. In my opinion, it's maybe a little bit like risk versus benefit. I feel like the benefit from a balloon pump, they say you're only going to technically get about a half a liter to maybe a liter worth of extra cardiac output, depending on what your situation is. So if you're really looking to benefit your cardiac output, it's not the greatest device. However, if you have someone who, let's say, maybe has an MI and they really need good perfusion to their coronaries, a balloon pump is really great for perfusion to the coronaries. Mm-hmm. So I think that
backflow to the heart,
like that backflow. I think that a lot of people, or I should say a lot of people, a lot of maybe newer nurses put them together. I mean, heck, we even have them together here. I know when I learned it, the class was together. I feel like we, as nurses, we learn them together and almost think that they have the same role. And in a way, they sometimes can have the same role when it comes to increasing that cardiac output. But I think that you kind of have to think about what is the true goal here.
Well, so like,
I always got them confused. It's like I couldn't remember which one did which. So.
Well, I mean, if you better perfuse your coronary arteries, your heart's gonna have a stronger pump.
Mm-hmm. Yeah.
So the impella is gonna help you. The impella is gonna actually push forward,
like perfuse, like the tissues, the organs, and that kind of thing. So it's more support, moving forward. But I guess I didn't realize that the balloon pump is much better for the heart itself.
It's better to, when you're talking about like perfusing the coronaries, because your coronaries get perfused right off the top of the aortic valve.
Right.
So like when it comes through that aortic arch and drips back down, that's when you get to perfusion of coronaries.
Well, I did not know that. I'm learning.
I could teach you. I'm better if I can draw a picture. I'm a picture girl.
This is a podcast.
Yeah, sorry.
We're not next time a podcast.
I'll wear a different shirt.
Definitely a different shirt.
we are, definitely, we can explore different apps at a different time.
But the thing with the balloon pump is that, they're inserted through the groin. So your patients, they don't necessarily have to be completely flat, but they have to be pretty decently flat. You can usually go like 15, maybe 20% degree, or not percent, but degree.
It's like percent. What's this? This must be some new technology. What's percent?
They don't have to be completely flat, but they need to be a decent bit flat in order for the balloon pump to actually inflate because it's going in through the groin. Versus the impella, I really like the impella.
Those people walking around.
Exactly. So the term I like to use with impella is they can prehab. So you put the impella in like an axillary approach, and they can still get up and move. The only limitation for them is usually, like if it's in the right axillary, they're going to have a little bit more like a limited mobility with that right arm.
Where they have seen like a sling, like as a reminder.
Yeah.
I feel like they can move it, but I think that we put the sling there, and I think that your facility no longer uses the sling, but because they want them to still move the arm a little, but not like up in the air.
Right.
They shouldn't be waving it like they just don't care.
Right. Because we care.
Yeah, we do care. We don't want them to lose muscle function in that arm. So like if we keep them in a sling for 3 weeks because they're waiting on a heart transplant, then like all of a sudden now we have that specific arm that can't move weeks later.
Or 2 months, 3 weeks doesn't seem like
3 weeks.
Yeah. Oh, okay. I was like, it seems like we're pushing them to the limits here.
Again, I like the impella because it can give you a really good amount of cardiac output. That like the upper limit on the impellas now is a 5.5, which means they can have an additional 5.5 liters worth of flow. Granted, that's assuming that their heart has that much volume to flow, but it's a possibility that it can go that high. But then also they're able to get up and move. So again, they can prehab.
I've never heard prehab. I
like prehab before they get whatever their goal device is. Because with the impella, they're stuck in the hospital. They're stuck in the ICU. They can't even go out to the floors.
Well, and what we're seeing for is pre-transplant. I mean, when I'd seen it previously, it was cardiogenic shock.
We still
like the heart can get better, with inotropes, or we'll come up with some like fixed dose or something, and then we remove the impella, and now we're seeing a long term waiting for a transplant.
They're able to for the seeing this, and I'm learning things as I go in this facility. Obviously, in my current position, but they use it to make the cath safer, like the heart cath safer.
I've never worked in cath lab, but I feel like I have heard that before.
I've heard a little bit about it, just how they're using it to support.
With impella assist, it'll say it on the actual case. It says like PCI with impella assist.
Yeah, it just makes it safer, which is really good.
Impella smart assist or something like that.
Well, that's
exact verbiage.
Lab nurse, to talk about that kind of stuff at some point. But so if you're a cath lab nurse and you want to come on the podcast,
my friend's mom is a cath lab nurse. Ooh. Well, actually, I think she might be post cath lab. Never mind.
Well,
she works with you. Right.
I was like, I know one too.
So
look at the whole table.
Well, about the LVAD. I mean, we talked about Denny. We talked about And a lot of people have heard the term LVAD or VAD. But this is, these people get to go home. Yeah. I mean, like, they get to go home with this device.
They get to go on cruises.
They do.
There are cruises.
Yeah, I mean, you hear stories. I think I've actually said this before. I mean, when I first went through LVAD training years ago, probably at least 10 years ago, they told us about like a kid who had, gotten a heartmate too, and he was a bridge to transplant because everybody was a bridge to transplant in the beginning. Went home and like tore out his drive line because he was on a skateboard because he was feeling so much better, and he's fine. I didn't ask that question. Is he okay? Because to me that sounds like a complete nightmare. But yeah, no, I mean, these people get to go home. They feel better. They suddenly have flow. Yeah. Where they didn't previously, and this is awesome stuff. Tell me about it.
So the LVADs, you have, I kind of explained this as you have like a funnel in the bottom of your left ventricle, and the heart, the blood from the LV or the left ventricle, it funnels down into this LVAD, and then it gets rerouted. Again, if I had a picture, it'd be easier to explain.
Like the apex, and it's kind of like, it just pulls it right up into the
regard.
Yeah.
So it kind of helps as a bypass from the aortic valve, if you will. So
like the left ventricle doesn't have to push it out. So we have an ineffective pump. Our left ventricle is not pumping correctly. So let's say we've got a 20% ejection fraction, and we're pushing out 30 cc's of fluid, and we're supposed to push out 110 cc's of fluid, 120. It's pulling that fluid off of the left ventricle and then shunning it up and towards systemic circulation. And it's neat. I mean, like, these people feel a lot better, a lot quicker, just like you were saying.
Well, I mean, they had like almost no perfusion. I mean, oxygenation was incredibly low. I mean, if you go from 30 to 110, you're supposed to have 110. I mean, you suddenly have oxygen in tissues that maybe hadn't seen a lot in a while.
So yeah, like you're increasing the person's quality of life and their mobility. But there's a lot that goes on with it. I mean, like, you've got a drive line sticking out of your body, so you've got like a kind of a cord sticking out of your body, and this dressing change that you need to do pretty frequently. And
talk about batteries all the time.
Don't want infections, and you've got to
measure battery.
You've got to be charged. You've got to have those six. You've got to have those 6 batteries.
Electricity equals life. Yeah.
And you can never leave home without your extra battery.
Yeah. Well, I mean, and people do. I've like had people come into the ED, like, you got a what? And I'm like, where are your extra batteries? And they're like, well, why don't you ask my name first? And I'm like, no, I want to know where your extra batteries are. That's my first question.
All those things are certainly true when it comes to LVADs. I think they have a lot of risk, but also a lot of reward when they are successful. The risks being, infection. The drive line needs to be maintained, with sterile procedure at all times. And then
bleeds for anticoagulation.
Risk for bleeds because we're inserting, and why did I say it like that? We're inserting foreign material into your body.
Yeah.
And that's just the body's natural coagulation pathways are going to try to coagulate your blood, meaning you're at greater risk for blood clots. So we need to give you anticoagulants like heparin, usually sometimes in the short term, but then you also can be on warfarin, Coumadin, a variety of other medications to help prevent your blood from clotting. But then those being on those medications put you at other risks, which are
risk for stroke, risk for GI bleed.
So they, again, when they're successful, they do come with a lot of reward, but they also come with a lot of risk. And I think that is how patient education is dire.
Well, I think the infection, I mean, that's what we see most commonly as a complication for these patients come back into the hospital for those drive line infections. And we preach and we preach and we preach about ways to combat that, and washing your hands and whatnot. I mean, all sorts of things, but it's really hard to keep somebody completely infection free whenever you do have a foreign object coming out of your chest.
I like don't they always say like the future state of this is like everything is inside of you, and you just like sit in a chair and you're like charging yourself. I feel like they say this in like that competency, like there'll be no drive lines in the future, and like you're just gonna like sit in this chair, and that chair has like
battery.
I don't know, like some of them.
It's like an iPhone, like a magnet.
Well, I'm not bidding on a VAD massager chair. a massager chair as we speak.
Oh my God. Yeah, he's awesome.
Well, anyway, I think that, so I obviously dealt with LVADs a lot in my experience at work. And then the very first time I was able to see someone outside of the hospital, I mean, people get discharged with these, I shouldn't say all the time, but all the time.
Doing pretty regularly.
Yeah, pretty regularly. But I had never seen someone what I call out in the wild.
They're out and about. Yeah.
Like people they go home with us out at the
living their life.
Yeah, well, the first
They're like holster. They're like, it looks like a gun holster. Yeah, with your like little batteries on each side.
Yeah.
Well, the first time I had seen one was actually at the local heart walk that we had like a year or two ago.
Well, that's appropriate.
Yeah.
But I was like, oh.
And they can walk. Their energy is doing great.
Exactly. So like not only was it successful for this person, but it gave them their life back. They were able to actually participate in this. I think it was a 5K, but they were able to participate in the 5K and like, again, a rewarding device because they were able to manage it appropriately. They were an appropriate candidate.
There's no way.
Gosh, I just felt so judged. I was like, can I do 5K?
Get out.
No, I can.
I'm going next year.
All right.
I'll go with
you. You just said that. So let's talk about real quickly the type of surgeries. I mean, we've talked about a few things, but I mean, your cabbages, your valve replacement and stuff. Like, we haven't really talked about the transplants much. The transplants seem intimidating, right? I mean, you're truly like giving someone a new organ. I mean, they come out of the OR. Like, what are your thought processes when it comes to
that? So with I guess we'll start with hearts. With heart transplants, you also want to be considerate of infection, just like when we're talking about the LVADs. These patients are going to be on anti-rejection meds, immunosuppression meds, a variety of different medications that
start that in though.
In fact, well,
it's even pre-op.
And we're going to start the protective isolation actually 60 days, like the second we insert that impella, the second we start that workup.
And also when education should have already started by then as well too. But a lot of times the patients, they come out of the OR hopefully healthier than when they went in because now they have a hopefully good functioning heart. So hopefully they're a little bit more stable. They might seem like they would be less stable because it's like, they just had a heart transplant. That's crazy, right? But hopefully if everything went well, they're a little bit more stable. Now that doesn't mean they're not going to be on still medications to help support and help.
Still fragile.
Yeah, they're still fragile by all means, but hope their heart is going to be working a little bit more cohesively with the rest of their body. I really do like heart transplants a lot. The other thing we haven't talked about is artificial hearts, which is something that I've had a unique experience to be able to work with at a couple different facilities.
It's in clinical trials.
Yeah, it's clinical trials. I've done at least two different. I don't know if brands is the right word.
Manufacturers,
yeah.
Well, there was two that's kind of been out on the market, and the clinical trial, started, and it was in the U.S. and then it was kind of paused for a little while, pump the brakes because there was some concerns, and then now they restarted it in Europe, and now they're restarting it in the U.S. But they've only started at a few facilities. But I think originally we were a part of, and we haven't restarted it at our facility just yet, but I know you were definitely a part of some of those.
Yeah, I've done some at y'all's facility, and then I did some at, I did a different one at facility in Cincinnati.
Yeah.
I was in. But I think that the artificial hearts, they're really cool.
Truly is taking the heart out of the body and replacing it with a mechanical device.
With a metal mechanical device.
I mean, this is cutting edge. I mean, this is this is straight off the Jetsons.
And those also come with that similar driveline situation as like an LVAD, but they're very interesting. But when I was in Cincinnati, we had a patient who did really, really well with the actual heart. I keep wanting to say transplant, but with the artificial heart, did really, really well with it. And I thought, this patient was doing so good. They were up walking. I mean, he was running laps, basically. Like he was good to go. I was like, sayonara, check this man out. He does not need to be here anymore. Let him go home. He's doing fabulous. And he actually was a bridge to transplant. And I was like that. I don't know. I kind of thought that there was, because it's still right now. Well,
yeah, I think they all are.
That was ironic. I was like, he's doing so good though. I always live by the phrase like, if it ain't broke, don't fix it. And I'm like, this heart is working fabulous. If it ain't broke, don't fix it.
Hey, I mean, I get it.
Yeah, ultimately he ended up getting a transplant, and he had a great outcome regardless.
But it's amazing.
Yeah,
but I'm so playing. Yeah, I do. That's something I'm really excited about. When I first came here, I didn't actually know that they existed. To be honest, I had been out traveling for a few years, and had not been in places that at least that I knew of. Of course, I've been in the ED. We don't always get exposure to some of those other things. So, when I came here, I was like, we can do what? So I mean, I feel like a kid. I get really nerdy, really geeky, really fast. I think our broom crew is already aware of that. But no, I think it's awesome. That we can do that kind of stuff for people, and to see. We love talking about these stories with people do well. I mean, we don't, as ICU staff, even as just nurses in general, we don't always see positive outcomes. And so when we do see one, we really grasp on it.
Yeah.
So, what some emergencies that you see? What about, some of the things we see? We come flying in there with somebody, they've got a tamponade or they're bleeding somewhere. Tamponade.
Yeah, tamponade is that's a scary one, especially when you've got somebody who is in the more immediate stages of a postoperative recovery. With that, anytime you have a heart procedure, it's just something you have to kind of be on the lookout for. We want to make sure that all these patients are. Anytime you open up somebody's chest, I can't think of a single time when I've had one of those patients that doesn't come out with a chest tube.
Oh, right.
So and usually it's 2, 3, 4 chest tubes. It's pretty much never just one. You're lucky if you got just one. Monitoring of those chest tubes. So obviously we're looking for bleeding. Anything greater than, I think they say specifically 100 an hour. In textbook world, anything 100 mils an hour or more out of a chest tube is going to be caution for concern or caution. I don't know. What are you
gonna be concerning?
Yeah, coffee.
We're gonna be concerned. Yeah.
But
or if it changes to bright red from Cirrus, But
I think that something that some of my I've had new grads who will be like, yeah, I've been checking this chest tube output for every 15 minutes, and it was 50, 50, 50, and then all of a sudden it's 0. And in their mind, they're like, great, they've stopped bleeding. But in my mind, I'm like, red flag, red flag.
Where is it?
Where did that blood go? It makes sense for it to slowly dwindle off. It doesn't make sense for it to stop. Yeah. So, of course, there's other signs you want to look for, too, when you're talking about tamponade. But I always kind of think about that as that's one big indicator. You really got to pay attention to those chest tubes. But otherwise, you're going to have that narrowing pulse pressure. So I kind of think of tamponade as we're basically squeezing the heart from all around. So when you start to see all those numbers come closer and closer together and start to equalize, that's a big, big indicator.
That's a good way to put it. Yeah.
Yeah. When you listen to your patient, if you hear those muffled heart tones, it means you're listening through fluid. That's quite literally.
So the heart is being squeezed to a smaller state, so we don't have a good systolic, we don't have a good diastolic, so those numbers are closer together. And since it's being squeezed by fluid, it's muffled. Yeah. That's a simple way to understand it.
Yeah. But when that does happen, when you truly do suspect tamponade, of course you certainly want to notify some people, or if you don't want to be handling that, people who can fix it.
So phone a friend.
Yeah, probably not the person that can fix it. While you can probably manage their blood pressure and do some other things to keep them alive, you're not the person who can fix the chronic syndrome. No. So you can do symptomatic management, but you cannot fix it. But really what needs to happen in that instance is they need to be opened up, reopened, and a lot of times that's probably going to happen at the bedside, especially for a night shift.
I was about to say, it's going to happen at bedside.
It's going to 2 a.m. at the worst time.
You're going to cut those wires.
Yeah. Which is scary. I remember the first time that it happened for me, and ironically,
go get the wire cutters.
Working that night, and you had a student with you. And I
see him not have a student with him.
He's I remember looking at the student and the student looking at me, and I was like, here goes nothing. And at that time, I had never opened anybody before, but like, I say it like I was the one doing it. Let's be clear. There, at that point, you're calling a surgeon or someone who's equally as qualified in to do the opening of the patient's chest. So basically, they're rescalpeling the chest, they're cutting open the wires. Someone else is physically doing that. But you, as a nurse, have to prepare to do all the other things. But I remember looking at the student and being like, here we go. Shit is about to hit the fan.
Yeah.
And I'm sure it did, but...
No, the times that I've been a part of emergency chest crack in both the ED and in the floor of the ICU, I'm just like, oh my God, I'm going to have to charge so much about this. Like, I don't even know where to start.
Yeah. But I've done a few now. I would say out of all the things that I've been lucky enough to not have to do them many times so that I don't... They don't happen very often, but it's when they do it, you're kind of like, man, I probably could have done XYZ better if I had been more like, what's the word? Not prepared, but like more, like practiced with it. You know, like we practice.
Yeah. Well, you
practice.
Yeah.
It's hard to simulate cracking a chest open.
Yeah.
And I think that when I was a brand new baby CVI nurse, not even a new nurse, but a CVI nurse, I think that we did have a simulation or like a mock of that, but it was one time. And that was probably 2 years before I had to actually do it.
Right.
So different.
Yeah. I mean, it's like that. I mean, like, you know, we're trauma.
There are those one-offs that you just...
Yeah. I mean, we crack chest and trauma. I mean, that was, you know, my background was local trauma originally. And, you know, we don't do it very often then. I mean, it has to be like, you know, penetrating chest trauma. And, you know, you have very specific reasons. I mean, and a lot of those patients, like, they don't really even make it to the hospital. So, you know, you end up losing the ones that you can maybe save in that way. So, no, I understand. It doesn't happen very often, and it always feels like chaos because, you know, you don't get to practice.
Yeah.
So, but no, I understand. So, yeah, I mean, I feel like we've covered so much. I mean, what are what's your advice for new grads? I mean, we've covered so many things. We're new grads or people new coming into the CVIC. Because a lot of times it's not going to be a new grad coming into the CVIC. I mean,
yeah,
for, you know, in most cases.
Do an externship.
Oh, yeah.
Do your capstone there.
Gloves up.
Get a 6 month long orientation. I mean, I don't think they're hiring new grads into CVI now unless you have done your externship there and done your capstone there. And you're going to have that, what is it? I mean, I feel like it was a 6 month wait.
I think that it is. I think
it's at least a 4 monther, if not a 5, if not
I feel like it was like
definitely
6+ weeks or something.
Depend on, I don't know if they quite go into 6 months, but I mean, I guess it really just depends on the person. Yeah, I mean, there's certainly been times where I've had an orientee who has struggled for certain concepts, and it's like, okay, let's give them an extra 3 weeks, or, you know, try to see if we can look for those, like whatever type patient population that they're struggling with. Like, let's see if we can get that specifically for them.
I was just thinking, did you orient me? Is she talking about me? Is she talking about me struggling?
No, I did not orient you. I would say that my advice is to learn something new every day. I think that for myself coming into the CVI world, or really even just the ICU world, there's so many different things, whether that be surgeries, whether that be medications, whether that be new specific labs that you're running that you've never ran before, to just look into those things and learn something new. You know, even if you're, you know, learn one thing each day. I think that,
well,
yeah, like, why are we drawing the mixed venous? Yeah. Like, ask respiratory's opinion on it. Like, you have such intense rounding there too. I mean, like with the providers, like, you know, and they're, you know, you're kind of running it. It's 25 minutes, and you know they expect you to go over every single system. But it's still a good time to ask questions. Why are you asking that? You know, like what's your specific concern with that? Because that wasn't something that I was worried about, and I see that you keep going over it. You've gone over it the past 3 days, so like, tell me what, you know.
Yeah.
Let's look at this as like interdisciplinary learning.
I love that you said this. So, like, Luke and I, we keep going over how important it is for everybody as a nurse, no matter where you
to feel comfortable,
to learn new things. Like, constantly learn, seek out ways to educate yourself, whether that's asking questions, because that is tremendously important. We harp on that all the time, but also like not just asking questions, but like seeking, ways to, literature, what have you. I mean, there's so many ways to learn. You can go to conferences, you can go, you can shadow, there's so many ways to learn as a nurse, and it's so important. But I like that, Norma last week's episode and you today are saying like, learn, always keep learning.
And,
I said,
and we didn't make them say it.
No. Wait, this is, no, I mean, we it's so important though. Like, I cannot stress it enough. Like, you see nurses who really get stagnant, doing the same thing day in and day out. I'm like, no, keep learning. Mm-hmm. You're going to see something new.
Oh,
I think that there's always a phrase that I don't know where I picked up the phrase from, but, to remember that you don't know what you don't know. So if you don't challenge yourself, you don't escape that box of like, okay, I know this.
We do this because we were told to do this.
Yeah.
Well, that's when we stay stagnant in practice, and we don't understand best practice. Yeah.
I cannot think,
because we've always done it this way.
That is so toxic. I mean, that is the most toxic phrase, is we do this because we've always done it this way. And I'm like, I hate that. Like, I never want to hear it, especially in healthcare, because it's like, no, like, what if we prescribe to that, thought process, like we would still be, just hacking all people's legs like they did in the Civil War. I mean, like, we would never have made any of these advances. We definitely wouldn't have ECMO or any of these, or impellas or things like that.
Yeah.
Because we have not always been doing that,
I think that I can relate it back to like when, I think that when I was a med-surg nurse, when I was coming out of orientation, people would say like, oh, how are you doing? I'm doing great. Like, I feel like I've mastered this. Like, I know what I'm doing. Right. And like, it's so like cocky to think, but in my mind, I'm like, I know what I'm doing.
Somebody's going to pull
and then, and then 6 months later, someone will say, oh, how are you doing now? And be like, I don't know what I was talking about back then. Like, I know so much now. Now I know what I'm doing. And then 6 months later, no.
Yeah.
Now it's constantly this like, now I know what I'm doing. I don't know why I said that when I said it back then. But then the other example is too that when I was studying for CCRN and going deeper on like the pharmacology behind medications.
Oh gosh. Oh.
I know that Levofed raises the blood pressure. Duh. Like, that's what it's for, right? But there's so much more than just that. Like, again, you don't know what you don't know. You have to dive deeper. If you think you know it all, trust me, you know. Trust me, you know.
No, I mean, that's
it raises the blood pressure at what cost? Basically, at what cost?
So anything else for our new people coming into the CVIC world or the ICU world?
I think my other piece of advice, especially in ICU, is to always be open to learning and criticism. That you are you're gonna learn a lot of things, and you're gonna probably think that you do know some of those things, and some of them you very well might. But you're always gonna come across people who are willing to help you learn, and just to be receptive to that, to take in what someone tells you. If it's constructive, know that it's not coming from a place of harm. It's coming from, hey, I'm your receptor.
Yeah, receptive to feedback. Like, I want to work with people that know what they're doing.
Yeah.
And, are challenging themselves to do well.
Yeah. I mean, I think we tend to gravitate towards people who are also learning new things and wanting to share those things. I mean, I think that's how we all became friends, is because we have very similar personalities. We're all kind of healthcare nerds, and
and we all cross stitch and play bingo.
I know.
Somebody won $2 this week.
It was me. I spent it on pull tabs. I'm sleeping. So
studying, yeah.
So yeah, I mean, I think, I have to reiterate what Laura's saying, as far as like, just continue to learn, and be open to the criticism, because it assume positive intent when someone is giving you feedback, Yeah, and then be patient with yourself whenever you're entering into a new environment that's going to challenge you. So just ask questions and be curious, right? So final thoughts, before we wrap this up, anything you want to add?
Well, I wanted to share a funny story. You guys posted on your
social.
I was going to say your Facebook, but it's probably a variety of your socials about fun stories to share with the class.
I love it.
So my funny story, I actually have a couple, but this one I think is my better one of the two. That kind of goes hand in hand with that. Be open to criticism. But as Luke said, in the CVICU world, you do very intense rounding with your intensivist or your NPs or whoever it is. And when I was new, the nurses kind of led the rounds. So you would have this swarm of people show up to your door, to your patient's door. I mean, quite literally.
Yeah.
And when they're ready, they're ready.
And all have one of those computer on wheels.
Yeah.
And they're all just staring at you. And I'm new. I'm not a new nurse by any. I've got a couple years of experience. I'm out of orientation. But I'm still new, and this is very intimidating to me. Someone who
it's like multiple doctors, multiple AVPs, throw in some students like AVPs and residents and fellows doing rotations, pharmacy.
It is a variety of people. There's so many people that show up, and then
they're like, "Are you ready?" Go through the system.
Yeah, quite literally. So I remember I had given one of the times I remember that I did break down. I was like, I can't handle this. This is too much. And I did cry, but I got better.
The one time there's nowhere to go but up and cry.
I got better, but now I'm like, I prep my not necessarily my students, but I prep my orientees, and I'm like, okay, they're going to expect you to lead this one day. So,
I thought you were saying you just make them do it. I don't know why she doesn't know it.
I'm telling her, but yeah. So my intensivist, we go through our spiel, and at the end of when you're done with your report, as if you would, because it's almost quite literally as it probably is as deep as you would go into a report with another nurse. At the end of it, the provider would say, she would have this small sentence of things that she would say. It's basically like a mental checklist for her. Infection.
We literally talked about this in our last episode. I love that you're bringing this up.
Can you remind me what all it was that you did?
So we would go over all of the ventilator bundle compliance, all of our infection control measures, proton pump inhibitor, STDs, at bed 30 degrees, subglottic suction, like that, all of that validation.
She would go through the list, and she would just say it so fast and not give you the time to to check.
They're validating.
Yeah, she would quite literally be like STDs, PPI, and she would just rabble it all off, and I would have to be like, yes, the STDs are on. Oh, not only are they on the patient, the machine is turned on. It's plugged in. It's plugged in. All that's good.
In the room. Look. Yeah. Yes. How about 30 degrees? Yes.
Yes. Those things are in check. But one of the things that she would say is lights. And in the ICU, we are very, very adamant about during the daytime, we want the lights turned on, the patient to stay awake as much as we can.
In the chair. You can go back to the bed in an hour.
Yeah.
An hour goes up. You can go back to the bed in 45 minutes.
Yeah. But the whole goal of it was to reduce or prevent ICU delirium.
Because it can be serious.
Because it is, and it was something.
Windows. Yeah. I mean, the medicines, the duration of.
It was something that we dealt with,
and
we were beginning to lower our numbers of it. So she would say lights, and I would say, I would look in the room. I looked in the room, and I look up at the lights, and they're on, and the patient's awake.
Say they're there. They're there.
No, I would be like, the lights are on, and patient's awake, and I remember I went through my spiel of yes, check, these things are done. And then she looks at me and she's like, I meant the electrolytes. And I was like, Oh, the different lights. The lights for the those lights. She was referring to
the computer.
She was referring to like, is the potassium replaced?
Yeah.
It's the.
But I mean, I could see it. Did you explain it, or it was just too weird?
I think back then I'm like, oh,
it's too weird at that point. Yeah.
Yeah. I think eventually she was like, I understand like why you would think
delirium.
Yeah.
Yeah. You just like shouted out. She's like, what? What are you talking about?
I understand why you would think that, but what I meant was the electrolytes. So yeah, she was a very intimidating intensivist until you like really got to know her, and then she was kind of a softie. But it definitely was like I was new and I needed to prove myself, and she was referring to the electrolytes, and I looked at the ceiling like I was like, yep, yeah.
I'm gonna do that.
Yeah. I love that.
I'm not telling that to my newbies.
No.
I'm like, you're gonna...
It makes you approachable.
Yeah.
You're like, get me that. I got through it. She said some...
You got... No, I do love that. It's like, gosh, we do... When we're new, like, you don't know what you don't know, and then you do sometimes say dumb things. I mean, I know it.
And I like to preface that with saying, no question is a stupid question.
No.
The questions you don't ask are the questions that I'm like, girl, you should ask that one.
You should ask. Yes, no, for sure. Well, thank you for being our guest. This is
thank you so much.
We've really, really enjoyed it, and I mean, gosh, we've gone over so much. Like, I can't wait to edit this because I can't wait to go.
It's going to edit so much out.
No, not at all. But I mean, we encourage you. Like, we want to go over, more ICU topics. I've got someone that we're trying to line up for trauma, and we've got someone we're going to talk about, coming in for medical ICU and talk.
Well, and I guess the cath lab. I want to know about CRNA school.
Yeah, we're going to definitely have you back on to talk about CRNA school at some point, because we're going to go over, like, the different pathways you can take.
Let me get my first intubation.
Okay, all right. We'll want to hear all about it.
Robert is going to volunteer.
Oh, yeah.
I see most people like himself intubate.
Yeah.
Oh, my gosh.
So yeah, but send, if you're working in a unique area of nursing, like, reach out to us. We would love to hear. And as always, like, we want you to reach out to us with questions, suggest topics. We do have an email address. It is codebrewpodcast@gmail.com. We're on Facebook. We're on Instagram.
Spotify.
And, we're on Spotify. No. And I can't get through the podcast without doing a plug for our merch store.
Shameless.
Shameless.
Doesn't say that.
codebrewpodcast.myshopify.com. Show your brew crew pride. We would love to see you out wearing something with Code Brew on it, or drinking from a water bottle or a coffee cup with Code Brew on it. So I'm not going to tell you what we're doing next episode, because I need to line up my next guest and make sure I've got them at the right time. But it will be something IC related, and I'm sure Luke will still be here to get on my nerves.
Get fired by them.
As always, stay caffeinated, stay curious, and we'll see you next time.
Thank you for having me too.
Thank you. Yeah.
Bye.